Hola a todos, muy buenas tardes. Muchas gracias por estar acá en la presentación de Mr. Raymond Schulz, que es nuestro ejecutivo de Medical Affairs, la presentación de actualizaciones del uso del LINAC para radiocirugía. Es con mucho gusto que traigo al profesor y al amigo y a una persona que tiene un conocimiento espectacular en radiocirugía para traer este asunto y discutir con ustedes todo este mundo maravilloso que está se descubriendo y se ampliando de la utilización de radiocirugía con los LINACs. Invito al doctor Raymond Schulz. Hello, Dr. Schulz. Hello, Dr. Raymond. Hi, Ray.
How are you?
¿Cómo estás? How's everything?
Great. Thank you so much for the great introduction, and it's a pleasure to be here to present at this virtual meeting. I'm going to be presenting on mostly radiosurgery, and this is my introductory slide. So at VARIAN, radiosurgery is a key focus, and you can see here some of the other focuses, but it is an area that I've been involved in for over 15 years, mostly at VARIAN, but for a few years at Accurate. And we're going to talk today about key market trends and growth, a little bit on LINAC development and advances in treatment planning systems, and the question about treating brain mets, in particular going from 3 to 4 brain mets to more than 3 and 4 brain mets. We're going to talk about our HyperArc solution and some thoughts about what can you do beyond mets. So in the US and in actually the Americas, the cancer burden is about 1.8 million cases with 600 or 700,000 deaths. And if you look at these pie charts, you can see various percentages of body anatomies that are cancerous. But what you don't see is a big missing part, and that big missing part is brain mets and spine mets, because it turns out that 20 to 40% of all primary cancers metastasize to the brain or spine, which means it's somewhere between 360,000 to 750,000 patients, which is a huge market. The literature says it's about 200,000, but we know it's larger than that. And we also know that there's been a tremendous growth in radiosurgery, and here's a graph from 6 years ago, and it keeps growing. And now SRS is recommended by NCCN, and we'll talk about that a little bit later. But you can see the rapid growth of radiosurgery. Now, there's a great paper presented by Drs. Hamilton and Lunsford. And Dave Lunsford is well known in the gamma knife world. And this paper had to do with looking at all the gamma knives in the world and how many treatments they were doing. And so the result of that was it looked like brain mets were, about 190,000 cases that were estimated, but only 10,000 cases being treated. And so a very poor utilization of radiosurgery in an area that has the great need. So as he states in the conclusion, is a worldwide consensus that major indications are underutilized for many diagnoses in the Americas. And here's where we can all help together. And radiosurgery can be performed by various linear accelerator platforms in addition to gamma knife, and that's also in this paper. So let's talk about LINAC. So it's very interesting that the very first radiosurgery treatment done in the world on a LINAC is from Venezuela, Dr. Betty. And he used, this is his first paper, and he used a VARIAN LINAC in 1982 that rotated back and forth, and whose chair went back and forth. And you can see in the summary, he says instead of using fixed entrance force, we use a pendulum motion of accelerator. We can distribute the dose, for example, 500 rez, an infinite number of points, which further reduces irradiation time that comes from dozen slices to a quarter an hour, as opposed to about 1 hour with 200 fixed points entries. 1982, he's comparing LINAC radiosurgery to gamma knife radiosurgery. And one of the comments in this paper is the only limit is imagination. 10 years later, we introduced our first dedicated LINAC radiosurgery system, and a number of those were installed at Harvard and at Thomas Jefferson. And here's a picture of that. And, you know, it was an old system, very old technologies, low dose rate, and so forth. And we've really come a long way since then. And in 2012, Varian launched the EDGE radiosurgery, dedicated radiosurgery system, which has two main components, part of the TrueBeam family, a brand new accelerator, which can provide dose rates, very high dose rates, the highest in industry, 2,400 monitor units a minute, and has an amazing maestro, we call it, with 10 millisecond clock, checking all of the systems at the same time, allowing you to do some very sophisticated things. And so this is a picture of the EDGE at Henry Ford, and these are some of the things that the EDGE can do that you can read for yourself. And it's important that the EDGE, you know, that whatever device you have sub-millimeter end-to-end accuracy, and that has been proven in multiple studies and multiple papers that you can see here, at the ISRS in Montreux and in the Journal of Applied Clinical Medical Physics. Well, what about treatment planning? So, you know, it's interesting that not only did a neurosurgeon have the very first Varian LINAC in 1982, but a neurosurgeon invented IMRT, Mark Carroll, who actually lives a couple of miles from here. And he invented Nomo's system, Peacock system, and Corvus. And so that was a very, you know, one of the most interesting developments from doing a parallel opposed to doing some sophisticated treatment planning. A number of years later, Dr. Carl Otto from Canada came out with something called VMAT, and Varian's version of VMAT is RapidArc. And what VMAT allows you to do is to modulate both the dose rate, the MLC, and the gantry speed. And so you have many degrees of freedom, allowing you to get really good conformality. And you know, and here's the comparison on the right, these charts that you can see. This was published at in the AAPM Medical Physics Journal in 2008. Here's a nice comparison between various treatment planning technologies on the same patient. This was published in 2018. 3D CRT versus IMRT versus VMAT. Now, when VMAT first came out, it was coplanar, so here's Carl Otto's paper. But you know, the only way to really cover the brain is to have non-coplanar treatments, and we'll talk about that. That this paper on the right from UAB in 2012 was one of the first. In 2010, Clark published this paper that talked about the idea of could we treat all of the targets simultaneously, because most devices, LINACs, gamma knives, cyber knives, all were treating one target at a time. And this particular sort of invention or technology allows you to treat all of the targets simultaneously as the LINAC is moving around, as the MLCs are moving, and you're opening the MLC to look at all of the tumors from the beam's eye point of view. Summary of the conclusion: VMAT radiosurgery will likely replace multi-isocenter techniques for linear accelerator-based treatments of multiple targets. And in 2012, he also published another paper, which is great because here's the recipe. How do you do this? How do you do the treatment plan? And one key part of this is these nested structures that we'll talk about in a bit. So let's talk about the concept of treating brain metastasis in the first place. Brain metastasis in the past have been treated mainly with whole brain radiation, but whole brain radiation has a number of deleterious issues. The patients don't really survive any longer with whole brain, and patients end up with cognitive defects with whole brain. But things have been changing pretty rapidly, and here's the latest NCCN guidelines. You can look it up for yourself, and things are moving very fast. And so the question is, what are the potential concerns for treating more than 3 or 4 Mets versus whole brain radiotherapy? Some concerns might be that, well, survival is going to be worse as the Mets increase. Yeah, so, and then the question maybe is, well, there's a high rate of distant failure as you try to treat more Mets at the same time. Or the toxicity will be too high as the number of targets increase. Or there's really no level 1 evidence, so why should we do it anyway? Or the planning tools are not available or practical, or maybe the delivery doesn't exist. So let's kind of go through each one of these. So survival is worse. Well, Dr. Yamamoto in 2014 in 2 different papers, Lancet Oncology April and Journal of Neurosurgery October, took a look at a large series of patients of over 1,000 and looked at the survival of those patients that we treated with radiosurgery, and their survival of 1 was better than 2, but the difference between 2 to 4, which was a standard and the maximum we were sort of allowed to do, versus 5 to 9, well, there was no difference. And then he did 6 months later another study, 2 to 9 versus greater than 9. Well, similarly, there was no difference, substantial difference in survival, and so that's not true. Okay, so what about the next question? So what about the high rate of distant failure? So in the same paper, if you take a look at this highlighted red area, you can see there's a slight increase in the effects, but it's not statistically significant, and so we would say that no high rate is there's nothing there. So that question is debunked as well. What about the question about if you have too many Mets? The toxicity is going to be too high because you're just treating it with too much radiation. Well, remember, this is radiosurgery. One of the key things about radiosurgery is you're putting a whole bunch of dose to small targets all at the same time. And Dr. Yamamoto did Mets, up to 60 and 40 Mets simultaneously, in stage radiosurgery with the gamma knife, and he saw no effect. And so that is debunked. So there's no impact on toxicity, and that's in this paper from 2002. What about level 1 evidence? Well, it turns out that at this ASTRO, there is now level 1 evidence that supports the 2 other papers that I mentioned to you about Yamamoto. This is essentially saying that the results in this phase 3 randomized trial strongly supports the use of SRS with 4 to 15 brain metastases to better preserve cognition function and to minimize interruption of systemic therapy. Now, that work was all done with gamma knife, and we know that gamma knife takes 30, 60, if it's 10 or 15 Mets, it might take a couple hours to treat. And I will show you how single isocenter multi-target multiple Met treatments can be very, very fast. So again, going back to this paper, planning tools are not available or not practical. Yes, it's available. So these planning tools, you saw the recipe before, and there's more recipes to come. So the paper on the left was the first recipe, and the paper on the right was a second recipe. So recipes are available, and in fact, the recipe that Dr. Thomas used for the neurosurgery paper shown on this slide on the right, where he compared gamma knife to LINAC, rapid arc to gamma knife. That was a much more sophisticated. You can see there's many more lines to the recipe. That was just published actually last month in the American the Advances in Radiation Oncology, and this was an interesting paper of 217 targets to 30 patients, 15 of which came from UAB, 15 of which came from Thomas Jefferson, and the conclusion was that for LINAC-based multiple metastasis stereotactic radiosurgery, rapid arc VMAT facilitates favorable conformity volume compared to MME, a dynamic conformal arc plan. So that's great, and there's more to come. So yes, there are plenty of planning techniques. So let's now talk about treating brain mets with LINAC and how we do that. So again, back to the question: can we fill in? We've got 190,000 patients, and only 10,000 have been treated with gamma. Can we sort of pick up some slack there and make patients' lives better? Now, it's not just the number of patients, but it's also the number of times the patient comes back, because here in this particular case, a lady with a lower lobe lung mass who was on immunotherapy, Presenta, she had 6 different radiosurgery treatments over a period of 5 years. Her first treatment was actually whole brain, as you can see up here on the top. But it's not necessarily the number. And as we get smarter and have more immunotherapy, focused medical treatments, chemotherapy, etc., targeted therapies, there are going to be more and more patients that are going to survive, and we're going to be sitting here trying to knock these tumors down. So again, this particular paper we talked about, and the conclusion here was that for multiple target stereotactic radiosurgery, 4-arc VMAT produced clinically equivalent conformality and dose follow-up as compared to gamma knife. And that was really important because in the early days, the literature basically said if you try to use VMAT and you compare it to gamma knife, that just the low dose pill was way too high. And the reason for that is in the past, nobody really paid attention to normal brain. And what you need to do is you need to set normal brain as a constraint. And that's exactly what he did in this particular paper, and using this particular formula. And here are the dosimetric results, the planned quality, conformity, and the planned quality mean brain dose is equivalent to gamma knife. And here's an example of a patient being treated, and we'll walk through this for a little bit. So that here you can see this particular patient had a resection cavity, which is this big, large tumor on your left patient, and a number of other targets coming up. And if I click here, you can see the jaws moving back and forth, the MLCs moving around the targets, and 4 different arcs, a 360-degree arc, and 3 170-degree arcs, plus or minus 45 and 90 degrees. 708 control points, 18 minutes, 5 minutes B-long time. And so now let's take us to the actual patient being treated. And here we go with the patient being treated, and bring up the patient in the normal way. Whoops. So you can see the patient being set up and so forth, and then cone beam CT is started, and at about 6 minutes, in about 8 minutes, the first arc, and so arc number 1 starts at about 8 minutes, and about 16 minutes, the last arc starts, and so we'll just spend a minute or so. LINAC do this last. You'll see the first arc and the last arc are going at the same shortly. It's finished. It's coming up on the screen. And 22 seconds, she looks at her watch, and the treatment is done. So that's great. So, but that particular patient was planned with this pretty complex technique where a series of nested shells for each target had to be created, and that's that complex recipe that I showed you. And you can look this up as well. So what's the answer to that? And the answer to that is HyperArc. So we spent a lot of time developing a technology that essentially did this very complex planning process and made it simple. And so this process is accurate, it's safe, it's efficient, and I'm going to show you a number of cases treated with HyperArc, and I think you'll be impressed. One of the other parts of HyperArc is this something so-called virtual dry run, where you can go through and check out and make sure the patient there's no collision and so forth. And so that's a neat tool that I don't believe anybody else has, but it helps you visualize where the LINAC is, where the patient is, etc. This, of course, is a phantom study, but that's pretty neat. And so the benefits of HyperArc is that it reduces planning time substantially from hours down to minutes. It probably the single biggest advantage is that it provides systematic, great quality plans. So even a sort of a moderately good planner can get great results without working really hard with HyperArc. And the treatment time was reduced by about 30 to 50%. So that's really cool. And we can plan within minutes, and we can create these non-coplanar plans within minutes. So let's go through a few cases. Here's a pretty impressive case. A patient was, his med-onc had him on Doxil, and actually it's a she, and didn't want to break that plan and the continued chemotherapy, and so she was treated for. She had 17 Mets. She had treated with 30 gray and 5 fractions in the past, and this is the treatment she's going to be given now. 4 arcs, 14 targets treated to 18 gray, and 3 targets treated to 15 gray in a single fraction, all at the same time. Here you can see the setup. Here you can see the cone beam CT, and then from 7:16 to 12:55, about 6 minutes, you have done is the beam on time, and the patient is done at about 13 minutes, which is substantial. Here's the each one of the targets, and you can see the Paddock and RTOG conformity index, and you're going through and seeing these very, very small targets, which is pretty darn impressive. So when targets are bigger, what you probably want to do is you want to do more fractions, because large doses to large targets are not good for the patient. That can cause some toxicity. And so this is an example of a patient treated 5 fractions, 6 gray per fraction. So that was treated probably over a period of 2 weeks. Just a good example of these very low dose spills and how easy that was to plan. So other treatments from other sites. This is from our friend Dr. Alongi and some treatments he did. This was presented at a users meeting that we had in 2018. So the before the treatment and post-treatment, before the treatment, post-treatment, pretty impressive stuff. So it shows you that radiosurgery really works, and the visual confirmation is impressive. Another series of 3 more patients, in this case, 1 in single fraction and 2 in multiple fractions. So, HyperArc is not just for brain mets. It can be used for anything, and that's, I think, we designed it for brain mets, but it could also be used for other kinds of targets. In this particular case, in the 2-week period in 2017, UAB did 59 procedures on 23 patients, 59 targets, and and 5 of them were non-mets, so you can see them with the arrows. And here are some other cases. So they've done the 9 acoustic schwannomas, and these are cases that the neurosurgeons really care about, making sure that you have good low-dose spill and high conformity. You can see that there are no margins here between the CTV and GTV, which is the way radiosurgery should be done. Same thing here for pituitary. There are 15 pituitaries they've done in the past, and 53 meningiomas. Perioptic tumors are another example of treatments that can be done. Now, what about hyperarc for non-radiosurgery cases? Well, the key part of hyperarc is it reduces low-dose spill. So if it reduces low-dose spill for brain mets or for a schwannoma or for a meninge, maybe you could reduce low-dose spill for kind of normal treatments. So here's some examples. This is an example of a malignant melanoma of the scalp where hyperarc was used. Sorry for the resolution on that, but so that's kind of cool. And so the dose was substantially reduced in the normal drain by using hyperarc's NTO, normal tissue optimization technology. Here's an example of Graves' disease where there are a couple of arcs that are used. And again, you want to. This is not a neurosurgical case. It's an ENT. It's an eye case, but radiosurgery is particularly effective for these muscles that are very thick because of Graves' disease. And here's a great example of parallel opposed versus hyperarc versus rapid arc. Look at the improved conformality. Visually, you can see the contours, and you see how the contours on hyperarc are really focused, and how this low dose spill is really low as compared to, of course, here you're getting lots of dose in the normal tissue, and even rapid arc is not as good as hyperarc. Head neck boost is another example, and that was the treatment done for head and neck boost. And what about this? So we talk about using whole brain for doing lots of mets, and that's maybe appropriate. We get way too many mets. So is there another technique that can use whole brain so that you don't have the cognitive issues that you have, when you're doing whole brain and the patient loses a bunch of cognitive. And so you can use something called hippocampal sparing, where you use VMAT, in this case hyperarc, to minimize or to completely eliminate the dose to the hippocampus. And this is really very important. And so this is another alternative for a patient that has so many mets that you couldn't possibly treat with radiosurgery. So that's important. This was presented at AAPM this summer, virtual AAPM, I might add. And so we have a bibliography of quite a number of papers. And I highlight 2 here. One published in Oncology in 2019, LINAC-based radiosurgery for multiple brain nets, guidance for clinical implementation. And so a number of centers that contributed to this. And here you can see the difference between multiple arc, multiple angle, hyperarc versus single coplanar arc and the low dose spill. And, it's great to see visually what, where the dose is going, and especially not where the dose is going, because you want the dose to go here. You don't want the dose to go in the normal brain, normal non-cancerous brain. And here's another nice paper from Rutgers University, multi-institutional dosimetric evaluation of modern-day stereotactic surgery for multiple brain metastasis. In this case, it compared gamma knife to brainland elements to manual VMAT, another version of manual VMAT to hyperarc. And if you look again visually across these images, you can see visually that hyperarc and gamma knife are about the same. Better than elements, better than single better this manual VMAT and this manual VMAT. And this conclusion, this study demonstrated that hyperarc VMAT is capable of achieving similar or slightly better low-dose spread in the brain as gamma knife, while maintaining excellent conformality as well as minimizing interplanar variability in V-monti for patients seeking treatment of metastasis. So just kind of wrapping up here a little bit, what we really are thinking about is, remember what Lunsford said. Number one, we really want to, SRS, the brain mets is, SRS is significantly underutilized, and especially for those patients that have brain mets that we're trying to treat with chemotherapy, immunotherapy, etc. We want to tackle this problem, this remaining 180,000 patients that we're not treating, that we could be treating, that are probably either not being treated at all or being treated with whole brain. So let's start thinking about that and how we can move to be treating more brain mets with radiosurgery. And in the next talk, if I'm invited again, we can talk about functional radiosurgery, but that was another part of this interesting graph. And finally, let's remember what Betty said, right? The only limit is imagination. We had no idea that you could treat, use hyperarc, for example, to do hippocampal sparing. It just was counterintuitive. But if you imagine what might be possible, and if you think about it and you kind of work it out, sometimes you can get some very great benefits. That's my presentation. Thank you for listening, and I hope this has been helpful. I know that many of you probably don't have these technologies, but there's something to look forward to for the future in treating your patients with brain metastases.
Bueno. Thank you so much, Ray. Wonderful exposition again. I'm always very excited to hear all these incredible advances. And hyperarc is really changing the landscape in radiation, in radiosurgery, and it makes us proud to see these advances, because it means that patients are less time in the table, and the staff is a little bit more comfortable and using it on the standardization of their practices, and definitely improving the usability. I would say that it's easier for them. So people from diverse parts of the world are implementing radiosurgery in a very high quality, and at the same time in a very standardized, in a very, let's say, intuitive way, which is, and also very powerful. We can see the results that are incredible dosimetrically, and hopefully with the time it's going to come very wonderful comprovation of the clinical efficacy of that. One thing that I was going to ask is, for hyperarc is not the only way of doing radiosurgery in our technology, isn't? Hyperarc is a one license, and in a whole operation, right. Yeah, for the machine and also for the treatment planning system. But we also are very able to do, or people are very able to do, multiple arc configurations with rapid arc, with dynamic arcs. Nowadays, much more with rapid arc, and also using now virtual cones. That it's something kind of a new, and that is under pretty much development, the technique, and being utilized also in other parts of the world. I'm not sure if you want to comment anything on that, Ray. I think it's important.
Well, so you're absolutely right. So it's a kind of big picture. We now have about 100 sites in the world doing hyperarc. I don't remember the breakdown, but about 100 sites. And by January of 2020, we will have treated at those 100 sites 10,000 patients. Now you imagine how quickly we have already grown, HyperArc, and how easily it was for patients to get treated on this. And so I think that we just imagine the benefit that HyperArc has had for those patients. Now going back to your other point about RapidArc, so of course, absolutely, if you have RapidArc, you can certainly look up the recipes that are now published and use those recipes. It takes a little longer. You have to, may need some help from others, but you absolutely can do a very good treatment for your patient using RapidArc. So one of the key parts of, again, one of the key parts that you need to do, because there have been some papers showing that VMAT is terrible. It's just the worst thing in the world. Well, it's terrible if you don't do, you don't make normal brain as a constraint, and it's terrible if you don't take the time to do these nested shells for each target. So, and if you don't have a good, volumetric arc therapy system, so you can use, RapidArc today. Many people do.
Yeah, in fact, one of the questions was, oh, sorry.
I would say one of the great things about a HyperArc is that, to treat with RapidArc requires a pretty skilled dosimetrist. And the more skilled you are, the better treatment you go. To treat with HyperArc, you can take a relatively unskilled dosimetrist and get the results of a skilled dosimetrist using RapidArc. So that's it basically levels you and makes all the treatments really good and very simple.
Yeah. So, but there's a lot of centers in the world that are using RapidArc in the regular form and as for radiosurgery, and with very good distribution that are meeting the standard criteria. A lot of places. But I was something else that was coming here. I was gonna answer in Spanish. The question was if the distribution in head and neck cancer is better with HyperArc or RapidArc.
Again, I'll answer it the same way I will answer for any. You can get a really good plan with a good planner with RapidArc. It's just harder.
It's just harder, exactly.
HyperArc seems to consistently give better than or equal to the best RapidArc plan.
Exactly.
You can equal a HyperArc. Are we talking about 5%, 10%, 15%? Again, it depends on the experience of the planner.
They are asking here if there is any experience with MAVs or neurinoma, acoustic neurinomas, and
right. I showed an acoustic neuroma. So that's the other really important question. So you can be a little. You can be. It's not. I'm going to say it's not as important, but when you're treating brain mets or when you're treating, treating disease, metastatic disease, has disease, the patient's going to probably not live longer than a couple of years. If you have a benign tumor, like an acoustic, like a pituitary adenoma, like a meningioma, like a trigem, if you have a benign disease, benign tumor, where you're going to live for, definitely because the tumor grows so slowly, for 10, 20, 30 years, that's where you be very, really precise. And that's where neurosurgeons become involved in. And so, it's really important on those. And so people ask me, well, so where are your benign cases? And that's why I made sure I showed you some benign cases in this presentation.
Exactly, absolutely. Well, dose distribution is dose distribution. If it's possible to have a very, very small region with a very good coverage and a decrease of those very fast, that's physics, and then that's what the machines and the algorithms are being able recently more and more of reaching that on our. So what about in other platforms? I know that we came to talk more on HyperArc and TrueBeam, but there is a question also about, and what about radiosurgery for a house on machine? Is it possible to do in a certain level there?
I think it sort of depends on the target. If you have a single target, you could probably do reasonable radiosurgery on a house cell machine. If you have multiple targets, you can still do radiosurgery. But if you don't have couch kick, which you don't have, or you don't have some other technique, then you're going to get larger low dose spill. If you remember that one slide that showed a coplanar rapid arc to non-coplanar rapid arc, where the big difference in dose distribution. So that's the challenge. You can treat the patient. It's going to be better than whole brain, but there will be, low dose spill. And so that's, it's if you don't have anything else, absolutely use it.
That's what I was gonna say. That, in fact, that's what I was gonna be asked by my question and my comment at the same time. So if they don't have anything else, or if there is, well, the site is isolated. So treating or not treating, the technology is not good enough. That is not able. It's not going to provide a good dose distribution, or it is acceptable.
My comment is it's probably way better to do a poor radiosurgery plan, as long as you are hitting the target with all the full dose and not hit the full dose in some other place. It's probably better to have a radiosurgery plan with not very good low dose spill than to have whole brain. Because a whole brain is a is a 5 to 10 day or 5 to 10 session treatment where you're blasting the brain with radiation. And and so for a long time we all thought that we were killing very small microscopic targets. But the literature that I showed today and that more and more people are presenting shows that that's just not the case. And there was a great study comparing radiosurgery to radiosurgery plus whole brain. And radiosurgery plus whole brain is definitely worse than radiosurgery alone. You'd think, oh, it's better because you're treating a microscopic disease. No, it's worse because the patient has whole brain and is getting the deleterious effect, cognitive defects of the whole brain treatment. So, yeah, that would be my...
Wonderful. Thank you so much.
I think the literature supports it, and that's what I tried to show in this talk.
Yeah, in fact, I was gonna even invite, I'm gonna say it in Spanish as well, everyone to go into the Varian Medical Affairs website and check different dose distribution plans, literature that are available. I'm gonna say it right now.
Right, so medicalaffairs.varian.com, right?
Exactly. Entonces, bueno, muchas gracias. Thank you so much, Ray, for your presentation. Thank you so much. Muchas gracias acá, InterOncology, por la oportunidad y a todos los que están acá nos escuchando en el día de hoy. Y los invito hasta ir a la página de Medical Affairs de Varian, y luego habrá Medical Affairs arriba. Y tiene la charla que pueden mirarla hasta domingo, está grabada, les dejo, estará disponible para ustedes que se queden on demand. Entonces, y en la página de Varian hay una opción de Medical Affairs. Allá hay un montón de casos de distribución de dosis, ejemplos en cabeza y cuello, ejemplo en cerebro, ejemplo con diferentes plataformas que ustedes pueden mirar. Distribución de dosis, pueden bajar el plan y evaluarlo. Y tiene bibliografía recomendada allá, bibliografía tanto de HyperArc quanto de tratamiento coplanar y no coplanar. Y entonces, Y cualquier cosa también les invito a que contacten a nosotros para más información. Y visiten también a nuestro stand virtual, que tiene información allá. Estaremos allá esperando a ustedes. Bueno, thank you so much, Ray. Thank you again. Have a nice day, everyone. Gracias a todos. Tengan buen día.
Thank you, Robinson. Have a great day. Have a great weekend.
Have a great weekend too, Mr.
Okay.
Bye-bye.